In typical NAM fashion, we're going to invite the next panel to come up and assemble as I introduce them, and that way we'll save time for more questions and answers, and our final reactor, Dr. Richard Frank. So again, thanks to Kathy and Eric, Richard and Ron. Now it's my great pleasure to introduce the co-leads of the Opioid Prescribing Guidelines and Evidence Standards Working Group. To my right is Dr. Helen Burstin, who's the Vice President and Chief Executive Officer at the Council of Medical Specialty Societies. To her right is Dr. Deb Houry, the Director of the National Center for Injury Prevention and Control at the U.S. Centers for Disease Control and Prevention. And following their presentation, we'll hear from the invited reactors, Dr. Caleb Alexander, Professor of Epidemiology and Medicine at Johns Hopkins Bloomberg School of Public Health, and Dr. Aaron Krebs, who's an internal medicine physician at the Center for Care Delivery and Outcomes Research with the Minneapolis VA Healthcare System. Let me ask you to begin.
Great. Well, thank you. As noted on the slide, we had a lot of different sectors involved in this working group. And I think it was important that, as we're looking at prescribing guidelines, we included healthcare associations, providers, but also the patient perspective to really understand the different impact. We had a lot of robust discussion in the beginning, and then throughout our different calls, we tried to really cull it down into what were more achievable objectives, and from that, develop some really specific activities that we'll go into. But we really wanted to look at what were some of the existing opioid prescribing guidelines already out there based on the best available evidence. When possible, how do we align them? And then really from the discussions in our group, one of the key things that came out was around tapering guidance. When we also look at opioid prescribing guidelines, we are wondering, is there enough literature around non-opioid or non-pharmacological treatments? And so initially we honed in on guidelines around those, but realized it was really more about how do you have multimodal treatments, and also how do you help navigate the system to access those treatments. And then finally, we also wanted to look at what are some of the quality metrics out there, and what are some of the unintended and intended consequences of these guidelines.
Excellent. Hi, everybody. Pleasure to be here with you. So we want to walk through our objectives for our work group. And first one, very importantly, we think it's critical that we actually begin to try to get to a harmonized set of guidelines. So one of our key action statements here is to collate and compare what's already out there in terms of existing prescribing, and as Deb mentioned, and tapering guidelines for specific pain indications, meaning we'll try to look at a subset of pain indications, but also across some categories, acute, subacute pain, et cetera. And really I think the key thing here is we want to look for where there may be differences that are not based on evidence. Why are there differences between specialties, for example, when the evidence would suggest they should be, in fact, a single approach? So really, to look for where those differences are that can't be justified based on available evidence. So we've got several activities laid out, and we'll go through each of these briefly. The first one, again, is this emphasis on tapering. I think we really saw there was a huge gap in terms of evidence availability, in terms of which patients to taper, which kinds of approaches to take. And so one of our first activities is to actually do a public webinar on tapering. We're going to bring together some of the leading experts in the field to help us understand where the evidence exists and where there may still be gaps in evidence, as well as how it might be applied in practice. Our second activity is a discussion paper that will hopefully pull together what are those evidence-based practices available for tapering. And then finally, a piece that would actually allow us to do the work of comparing and contrasting the various opioid guidelines from the different specialties for a subset of clinical indications. Our thinking is we're delaying this slightly because we are aware that CDC has some very important work coming out this summer that will further the work on guidelines for specific indications. We don't want to recreate the important work that they're going to bring forward. We also recognize that there are varying levels of the quality of evidence that feed into many guidelines, and we want to stick to the top, highest quality evidence that we can.
There you go. On objective 2, again, wanted to look at non-opioid options, both medical and non-pharmacological treatments. And so Bob Twillman and his group had pulled together an integrative congress really looking at all these different multimodalities as well as issues around barriers to access to care, whether it was payment or other. And so looking at some of those discussion papers, there's a way that we can collaborate and work with him on those, and then really have a communications effort around that, because again, papers are great, but they sit on a shelf, and if patients and the public don't know how to access them and have it translated into tools, it's not as helpful for what we want to really do when we're trying to really enlighten people and let them know what options there are. And along with that, looking at potentially a CMS model, they had a great patient journey map that we saw yesterday around how do you navigate the different points of care. If we're talking about different multimodal options, what is one versus the other? What are the benefits? How do you access it? And one of the things we've also talked about in our group is, although this is geared for patients, we know that providers will really utilize this, that and many other instances when groups have done patient-type documents, providers really utilize them. So make sure there's also ancillary materials for providers to then utilize so they can really have that shared decision-making with their patients.
And finally, for our final objective, and these are all pretty big objectives, so it's only 3, but there's a lot packed in each of those, we really want to look at how to support the implementation of these pain guidelines. So that might be into electronic health records, into clinical decision support, into metrics, as we've already talked about this morning with Gary's talk. But we also, very importantly, want to do that while monitoring for both intended and unintended consequences of those actions. So our first activity is we would like to conduct a series of listening sessions with different audiences to help elicit input on what are the potential intended and unintended consequences of these opioid prescribing guidelines and related metrics. And so we'd love your feedback on this as we go through the panel, but we at least would like to make sure we're doing listening sessions with patients, with providers, with health systems, potentially even with health departments, to understand where maybe there are some barriers that have been put into place with good intention that may be, in fact, limiting access to pain management for patients who really need it. So we think that's a really important first opportunity, and we want to make sure people understand that we recognize that there may be unintended consequences while we're trying to seek a set of intended effects. So we're then going to summarize a discussion paper of what we've heard from those listening sessions that we'll build on going forward, and then finally we'll actually pull together, working with other entities who are looking at measures as well as clinical decision support rules, to really say what is out there that we could start embedding into the way clinicians practice so they can rapidly access what is the best available evidence, what are the best available treatments, and use them to get to the best opioid prescribing guidelines. Thanks.
My turn?
Your turn.
All right, great. Well, thank you. I'm Caleb Alexander. I'm one of the pointy-headed one of the pointy-headed academics in the room. But it is a privilege to be here, and I thank both of you and those of you that organized this event for the opportunity to participate. And I've organized my comments around 8 observations and queries that I'll pose to the working group directly. The first one just has to do with how rapidly evolving and complex the opioid epidemic is, and the fact that evidence will continue to accrue, enormous amounts of evidence, even in the 6 to 12 months after the working group's activities are completed. So the question for the committee is, or the working group is, how will you maximize the enduring relevance of your undertakings? The second is that the field is crowded and everybody is trying to stay relevant. Many years ago, Reese Witherspoon won an award, and I'll never forget, she said, "I'm just trying to make a difference." And I think all of us feel that way, and I was pleased to see, for example, the NCQA identified and called out in some of the materials I reviewed. But the query for the group is, how have your activities been informed by other organizations' efforts, and how can such complementarity be maximized and continue to be maximized as the work continues? A third point has to do with the enormous breadth that the working group is proposing to tackle, from tapering to integrative pain management to coverage and reimbursement to clinical decision support to unintended consequences. And my question is simply, is this breadth worth it? You know, is it better to do 5 or 6 things pretty well than do 2 or 3 and knock them out of the park? A fourth has to do with some areas that I think are fraught with challenges, such as identifying guidelines across specific clinical indications, although I'm aware that this leverages work that is underway or perhaps has largely been completed. So perhaps I should be heartened by that. I understand the appeal, and I certainly understand the rationale for focusing broadly on different settings of care, acute pain, post-operative pain, and the like. But it's not clear to me the ease with which one can examine condition-specific indications, such as low back pain versus chronic migraines versus osteoarthritic pain and the like. And so the question is, has the relative value and anticipated impact of the different work products been carefully evaluated so as to maximize return on investment? The fifth point touches upon the potential collaboration with the Integrative Pain Care Policy Congress. And while their activities may be of great value, it's not clear what process you or the NASEM use to identify this collaborative opportunity. And I think this leads to a question regarding whether the rationale and process for deciding upon a potentially formal collaboration with an external organization has been clearly and transparently articulated. And how does the alignment with one organization affect the perceived neutrality and rigor of the NASEM's broader action collaborative? The sixth has to do with the emphasis on unintended consequences, which I was really heartened by, and I think it's probably one of the areas where there's the most heat relative to light in this debate and in the epidemic writ large. But rigorous empirics regarding unintended consequences would seem to be a precondition for evaluating how these can best be avoided. And so the query for the working group is really, how carefully, or have you carefully considered how your treatment of unintended consequences can best be integrated fully into your activities? The next to last point is related to the imperative to find common ground, since so much of the genesis of the epidemic has been a tug of war between opposing narratives about pain management and addiction treatment, or the prevention of the oversupply and overuse of opioids. But there's much more common ground than we might think, or than one might think at first glance. So the question for the working group is, how have you preemptively maximized alignment that may otherwise diminish the impact of your work, especially from the community of individuals and stakeholders representing those with chronic pain? And the last point is a related one, which is that this isn't just about science, it's also about politics and policy and organizations with enormous vested interests. So while it's enticing to think that these are well aligned, we know all too often that they're not. And so the question for you is, how will your undertakings be informed by this fact and the historical underpinnings of the opioid epidemic? So I often talk with my father-in-law about my work, and he's a tax professor at the University of Austin, or University of Texas, but he always says, for God and for country. And you know, I think indeed keeping a focus on our true north is vital as we continue to turn the steamship around. So I do applaud the NASEM and this particular working group for your important efforts, and for all of you who will be carrying the water in this task. Thank you again for the opportunity to be here.
All right, and I think this is on. So we did not actually plan this, but it turns out that we were on the same page and that Caleb finished really where I wanted to start, which is that I've been thinking a lot lately as, you know, I am immersed every day pretty continuously in these issues. And I've been thinking a lot lately about an issue that we often don't really discuss openly in mixed company, but frankly is something we really do need to talk about as we talk about how to address the opioid crisis. And that's the extent to which the opioid industry influenced us, not just individual people with financial conflicts, but the agendas of our societies, our organizations, our conferences, even fundamentally how we think about the problems related to chronic pain and addiction, and how that might still be influencing us. Some of the things that just seem like common sense or the way we talk about things are not accidental and not really science-based. They are stemming from this long-standing influence. And, I think as we ask questions, any scientist knows the most important part of a project of research is getting the question right, really thinking about how we have asked the questions and what we are thinking about, how broadly we consider those questions. That's the most important thing. And I think it's especially important here and very important for prescribing guidelines and evidence standards. So I have fewer than 8 questions, but I think I have one really big one, and that is, what is the role of opioid prescribing guidelines as opposed to pain management guidelines, and more specifically management guidelines for specific conditions? Because pain is not one thing, it's not even 2 things or 3 things, it's a vast different number of clinical conditions. We have a crisis that is clearly opioid related, and it needs to be addressed head on, so that is an argument for opioid prescribing guidelines. I think of the CDC opioid prescribing guideline for chronic pain as really being a landmark moment that caused us to all start thinking differently about opioids. And so in my view, that was a case where it absolutely was important to have opioid prescribing guidelines. But think about all the other health problems, chronic diseases, acute conditions, and think about, do we have guidelines focused on one specific therapy for that condition? Or do we have guidelines focused on the condition and its management overall? So I think we do need to remember that much of the root of our crisis is pain mismanagement. And as we focus on opioid prescribing, as opposed to pain management, there are potential harms. I would say 3 things in particular. First, when we focus on opioid prescribing guidelines, we are implying that opioids are a standard, preferred, and core therapy for the condition at hand, even sometimes referring to the condition as an indication rather than a health problem. And I'm not trying to point fingers here. We all do this. Our minds have been kind of colonized by this way of thinking. I think there's no doubt that early opioid prescribing guidelines had the effect of normalizing, spreading, and intensifying opioid prescribing, even though that was often not the intended message. Frankly, my second point is that the evidence for opioids looks quite different in the context of the evidence of all therapies for a pain condition. This is why if you look at osteoarthritis, like knee osteoarthritis guidelines or low back pain guidelines, opioids barely take up any space in that text because they're simply not preferred. Their evidence isn't very good, they don't seem as effective, and so the guidelines focus on the more effective, better supported therapies. Finally, a big one, I think there is an opportunity cost when we focused on opioid prescribing, in that that clinicians and the public at large are not informed about therapies for which we do have evidence and that are the standards of care for these conditions. So I don't know when it's time to move on from opioid prescribing guidelines. Like I say, I think the CDC opioid prescribing guideline was important. It may be that we need some more opioid prescribing guidelines, but I'm not sure. At some point, we do need to move on, and we need to get back to focusing on our conditions here. At least we should be thinking very explicitly about why we make these decisions, and be clear about what is pain and what is opioid management, so that the two don't continue to be blurred and conflated with each other. So that's my big point. Secondly, I think if we agree it's important to focus on opioid prescribing guidelines, I'm not sure what we can learn from their inconsistencies, and I struggle with how we can increase the likelihood these guidelines will improve care. We have to acknowledge the state of the science about opioids, which is very poor. We will find very little evidence for any specific opioid management strategy. And therefore, very few recommendations in these guidelines will be based on good evidence. They will almost all be based on expert opinion. And the differences between them will be based on which experts were in the room. And as Caleb mentioned, there's a lot that goes into that. So it might not be an achievable goal to harmonize opioid guidelines, even in areas where we have tons of evidence. I'm a women's health primary care doctor, and I face the hot topic of mammograms and breast cancer screening. That's a topic where we have vastly better, larger databases, more evidence about what we should be doing, and yet we cannot agree. So the same thing occurs, I think, when we think about decision support rules and standardized metrics. Around opioids, some of our decision making is just so complex and individualized, not based on evidence because we don't have it. How can we improve on that state with tools that work best when we have good evidence, when we have clear, correct answers, clear standards of care? Tapering is a great example of this. So this is a topic where clinicians are just desperate to know how to do this right, how to do it better. And of course, tapering is a clinical intervention. It is intended to address a clinical problem, which is opioid dependence, right? And when I say opioid dependence, I mean that broadly. Someone who's been taking long-term opioids and cannot just stop them. So what is opioid dependence? This is, again, where we have conceptualized this concept as a very simple problem, separated from addiction with a bright line, but it instead turns out to be a complex biopsychosocial phenomenon that is diverse. Have we even really understood what it is? How do we agree on what it is? Unfortunately, I think creating evidence-based guidance for addressing it is a long way away. So for the foreseeable future, tapering practice will involve a lot of careful, individualized care. And I will leave it at that, at least those big questions today.
That's great.
That was absolutely terrific. And, I just warn you that to the reactors, this is, NAM is a little bit like the Hotel California. You can never leave. So you've given us such robust information to think about that we look forward to working with you. But with that, join me in thanking this terrific group, Helen, Deb, Caleb, and Aaron, for terrific work.